So today we are having Dr. Chitra taking a session on mental health for us. So we can start with ma'am's presentation. We can have it for around 45 minutes followed by 15 minutes of discussion. We can start our case presentation by 4 o'clock. Yes ma'am? Yes ma'am.
The schedule was not for 45 minutes, it was only for 30-35 minutes. So I'm not going to speak more than 30 minutes. And I have to leave sharp at 4:30, before 4:30. So I cannot keep doing it for a long time. So I have kept it only for 30 minutes because the schedule says only 30-35 minutes. So 45 minutes per minute. So,
Okay.
okay. And finish it quickly.
Okay, sure. Over to facilitator.
So thank you so much, Chitra ma'am, for accepting our invitation. So for the participants' information, I would like to introduce Dr. Chitra. She is a professor and head the Department of Psychiatry and senior consultant in palliative care and psycho-oncology at Believers Church Medical College Hospital, Trivandrum. She is also the director of Mehat Foundation. Mehat is the Mental Health Foundation. So welcome, ma'am, and once again, thank you so much for your sparing your time and finding this time to us. Over to you, ma'am.
Will you be showing the presentation? I had sent it. Or you want me to share it?
I can share it, ma'am, if you want.
Yeah, but then can I move it or I cannot?
No, sir, ma'am. If we are sharing it, we can only move it.
Okay, then I'll do it. I'll do it.
Okay, sure, ma'am.
CCF team, kindly unmute yourself. CCF team, kindly unmute yourself.
Can you see the presentation?
It started sharing, ma'am. We can't see the slides.
Can you see now?
No, ma'am.
No?
No, it's just a plain screen, white screen coming up.
Okay.
Yeah, now it's perfect.
Okay. So for the next 30 minutes, I'm going to speak about, so the two sessions that I'm going to do for you is about the mental health and palliative care. So we are not going to talk. We are not going to talk about purely like psychiatric issues or anything, but we are going to talk about generally as mental health. What does one person emotionally experience during a chronic disease, and how is it relevant to a palliative care team, and and how do we make sense of distress, in emotional distress in palliative care. So that is what I'm going to speak about today. And today I'll be speaking only about how we make sense, in the sense of what are the concepts that we should follow, what are the ways that people express emotions, or what are the ways that people would respond to illness. So very basic way. I'm just building up the foundation so that the next session we'll be talking more about psychiatric disorders, management, and difficult situations that people go through. So today is just understanding why we are doing this. So before I go into it, I wanted to say that there are many studies looking into the emotional distress of people. And one of the studies I wanted to say, especially because we are talking a lot about end-of-life care these days, talking about euthanasia and, how we are fighting for, giving better quality of life and better quality of dying also for the people we care for. This study, which is a study years back, but when you look at it, the reasons for request for euthanasia by a group of people, and this is again in Europe, if you look at the causes, see, pain is 46%, but the rest of the things, loss of dignity, 57%, unworthy dying, like they think that the dying process is not it's not worthful, dependence on others, and also getting tired of life. Ultimately the reasons are predominantly psychosocial. So often what happens is when we take care of people, we focus on the physical aspect and sometimes tend to kind of minimize or tend to not give as much as focus to these psychosocial reasons. And when we talk about psychosocial reasons, I'm talking about the individual experiences that a person would have when the person is going through a journey with a chronic disease. And nearly 60% of our palliative care patients experience emotional distress. This is again a study based in North America, which showed that there's a good percentage of people experiencing emotional distress. And if we give care, and especially if we have methods to improve education about the psychological issues, it improves anxiety, depression, mood. And not only that, it improves the physical symptoms like nausea, vomiting, pain in cancer patients. That is again a study which showed that if we take an effort not only to give care but also to improve the understanding and the knowledge about psychological issues, that actually improves not only the psychological issues but also the physical symptoms that a person goes through when it is a chronic disease. So I'm just going to bring in a case study here. So this is about a 68-year-old man who just received news that he has lung cancer. And he has retired from work as a cleaner. He's in financial difficulties. A cleaner means a manual laborer. He has recently lost his son, but he's supported by his wife. When he comes to you, he's got the news. He says that he's very tired. He's overwhelmed. Overwhelmed means because of the news, he's feeling very dazed. He's not sleeping. He's getting irritable because he feels that nobody's understanding him. So this is the case study, that when you see someone and they have a lot of symptoms, but what happens is, see, when he says he's tired, he's not sleeping, the usual method that we follow is that we assume or attribute these symptoms to the disease process. Okay, he's got cancer, so it must be the disease process. So is there a metastasis? Or we would, if suppose he already chemotherapy or some radiotherapy has started, we will attribute the tiredness or not sleeping to the treatment regimes that he's getting. So other than that, always attributing to the physical symptoms. They are very important. I'm not saying they are not important. The physical symptoms and the causes, like the environmental causes, the treatment causes, the illness causes, are very important. But we have to always also give room to understand whether this is an emotional response from the person. So I'm going to now talk about a few slides about reactions to illness. So the emotional or psychological reactions to illness that a person can have. And when I'm sure that all of you have heard about Elizabeth Kubler-Ross. So this model that Elizabeth Kubler-Ross contributed, not to palliative care alone, but it's a general model of loss. That is, when persons lose something which is very dear to them, especially when it's related to life and death. Okay, they go through phases which helps them through the process, go through psychological phases, and they reach to a stage of acceptance. And this is a very normal process. This is not that it happens only for patients. It happens to all of us when there is a loss. Am I making sense? Okay. So usually, for the matter of convenience to understand, it need not be like every person has to go through 5 stages. Kubler-Ross actually talks about 5 stages. 5 stages that a person goes through when they are told that they have a terminal. For example, when they are told they have a terminal illness. This can be when a person loses somebody by death, or this can be when a person is told that they have got a serious illness. This can be when a person has a serious accident and loses a limb. This can be if a person is raped by somebody. So this can be any situation where the person is facing through very stressful and unpleasant state. So this person, when they have told something or when they go through this, they usually go through 5 stages as per the model. That they go through denial. The initial stage is denial, where the person is actually very numb and in a state of shock and is almost doesn't believe it. There is a sense of disbelief that, I don't understand what is happening. I don't think this has happened. I don't believe that my father has died. I don't believe that I have cancer. So this is a kind of difficulty to accept the reality, slowly progressing into anger. Why is this happening to me? I have not done anything wrong. Why should I be the one that has to suffer? Why is God punishing me? So these kind of questions. And then going into bargaining, talking to God about, I have been very good. Why have you done this to me? Is there any way that I can, if I do, I'll pray. I have prayed. I'll pray more. Please save me. So this kind of bargaining. And then again, the certainty of the condition hits and they go through a period of despair and depression and then finally acceptance. So these are the stages that Elizabeth Kubler-Ross actually explained in terms of reactions. It is not necessary that every person has to go through these 5 stages. Okay, a person can immediately, directly go into a stage of acceptance depending on how his coping resources are. If I am able to cope well, I would definitely be able to pass the stages very quickly. A person who's got a very difficult situation, has very poor coping resources, might get stuck in some stage and probably just stuck in depression. So it is not necessary that everybody has to go through this. You can jump the stages, you can go directly, or you can get stuck in one stage. So actually, like I said, it is a continuum of behaviors and the reactions can merge in and out. And at one time of the assessment, one will be standing out more than the other. Like what I mean is, if suppose that 68-year-old man, you're meeting him and probably you'll be seeing him very angry at that point, saying that the doctor didn't tell him, or, the doctor has not been kind to him, or, his family didn't tell, whatever be the reasons are, he might be angry. But maybe in an hour, he might be denying. So it need not be in order, or at one point of an assessment, one emotional response could stand out more. And there is no strict time period, but generally we think that this whole process takes around 6 weeks, maximum of around 2 months maybe. And after that, the person normally, after a loss, gets back into a stage of acceptance, and then kind of, the person tries to then find out, or, replans his life and tries to live the life with the present situation. Is it clear?
Yes.
So I'm going to talk about, when we talk about reactions, it's also about coping. So I'm going to talk briefly about coping because we need to know about this process called coping. Coping is how each one of us, when we are faced with a very stressful situation, it happens daily in our lives. And when it is like when you're told something very serious, that happens seriously. It's a matter of life and death. So when you are facing stress in your life, you have to cope. That means we have to bring the resources within us to overcome that, adapt and adjust to the new situation. Isn't it? All of us do that. It can be for a small minor issue to a very major issue. But when you're looking into chronic illness and coping, very important that when that man is actually being told that he's got lung cancer. So what happens when when somebody tells you one fine day that you have got a serious illness? Everything changes, isn't it? There is a change of plans suddenly. You would have planned a lot of things for next week, next month, many things, like simple things like, visiting somebody, going for a marriage, doing this, spending money for this, not buying things for your children, whatever it is. But suddenly from that moment, the plans start changing because everything gets focused into your illness and the treatment or whatever you have to do because of the illness. You change your view about oneself. That means I start looking at myself as a patient, as a sick person, as someone who is very vulnerable, as someone who is suddenly lost identity or lost a role in life, somebody who has lost control of what is happening in my life. Suddenly, it highlights my vulnerability. I have become this person who Now I'm dependent on several other persons. I'm not able to do things on my own. I'm so emotionally weak. I'm so physically weak. So that highlights one's vulnerability. And of course, there is an element of uncertainty. What is going to happen to me? So it starts from what is actually happening to me if the doctor or the team hasn't told the person about the illness. It is also like, what is actually happening to me? I don't know what is happening to me. Am I actually dying? What is the information I have about my illness, the cause of the illness, outcome, treatment, etc. So that there are illness related factors. Is there a greater threat? Because if there is a greater threat of the illness, suppose there is multiple metastasis in the beginning itself, it's a greater threat. That means there's more difficulty coping. Sometimes there is disfigurement. That means they undergo tracheostomy or they undergo major surgery. If there's head and neck cancer, that is an illness-related factor that leads to difficult coping. Embarrassing problems, like having a stoma, having, difficulty vomiting or, passing urine or stools unknowingly. Very embarrassing issues. Loss of hair due to chemotherapy. Visible conditions like seizures, tics, pain, which we see every day in palliative care, every day in our practice, chronic pain, acute pain. The time commitment for treatment regimen. Sometimes you have long periods of chemotherapy and radiotherapy planned. So months and months of this treatment and you're losing in touch with your life and your peer group. So you need a lot of lifestyle changes. You might even have to shift to the hospital to take these therapies. So all these are illness-related factors which can affect your coping with the new situation. Behavioral and personal factors. So one was the illness-related factors. Now I am talking about behavior and personal factors. That means good copers. That means people who have been coping well in the past are expected to cope well in the present also. That means if I have been facing dilemmas and crises in my life in a fairly better way, I might be able to face that better in my life. Not necessarily so, but it is expected. But if a person has always been anxious, vulnerable, always dependent on others, that person might have a difficult time coping than a strong coper. It is said that men have more difficulty in adjusting to chronic illness than women. Because the loss of role and the identity as the dominant person in the family, being the breadwinner, being the strong person in the family, suddenly becoming someone who's weak makes them feel much more weaker. The timing during the lifespan affects reactions. That means whether you're a child, you're an adult, or an elderly person. See, an elderly person who is around 80 or 90 may suddenly straight away accept it and say, I have lived my life, so I'm okay, I'm not worried, doctor, you do whatever you want to do. Whereas if it's an adolescent or a child, it might be much more difficult the way they understand the illness and how they cope. And of course, our own personal health belief issues, our own fears, our own beliefs about cancer, what our family experiences are. Have we had experience of cancer and death in our family? Does that already make us very fearful or apprehensive about cancer or any other illness? So our own personal health belief issues are very important. The physical and social environmental factors around us. Hospital environments can be very depressive. Home and hospital environments may not foster self-sufficiency. What I meant is, especially in a country like India, our culture, the family takes over and actually they take care of everything, and the patient is actually seen as a very helpless and vulnerable person. And that person is actually not encouraged to be self-sufficient. They are encouraged to be sick, which is actually also not good. People also, if they have the strength physically and emotionally, they should be allowed to take decisions. They should be allowed to make choices. They should be allowed to come to the hospital with planning their own schedule and not according to the family's vision. And also about social support. What is happening in the society? How is the community supporting them? How is the religious society that the person belongs to supporting them? All these issues are very important. So what does psychosocial functioning task actually mean? What does the person have to do? Psychologically, what do we want to be? We want to control negative feelings and we want to remain positive, isn't it? That is every day. We don't want to be always negative. We want to be positive. We want to maintain a satisfactory self-image. When a person sees us, you want to have a very adequate self-image, physically and psychologically. That means you are actually not having any negative thoughts about your body image. Also, you're not having any dissatisfaction about the emotions that you feel, which reflects as a person. You want to preserve good relationships in your family, in your community, with the doctor and the team. So you also working towards having very positive relationships so that you know that you will become dependent on them. You will want to, this is a long-term journey, so you will need all those people. And also, you know that the future is going to bring something uncertain. We don't know. And especially with some knowledge of cancer, you know that it can come back, or if already you have a serious illness, you know that there might be pain, there might be, death happening, whatever, to mentally start preparing for the uncertain future. So these are the psychosocial functioning tasks that we are looking into. So what are the reactions that usually we see in people? So I'm going to divide them into two lists. Okay, one is the adaptive behavior and another is the maladaptive behavior. When I mean adaptive behavior, these behaviors help the person adapt to the situation. That means this helps in coping. That means even if you're not able to fix the problem, that means we cannot fix the cancer, but the person with these behaviors adjusts to the situation of cancer and helps the person to overcome the stress related to it, or the emotional task. What we discussed in the last slide becomes easier for the person. For example, humor. That means people take it in a very cheerful manner, not very common, but this happens in older patients when they say accept the illness, or in a very cheerful way, or there are people who say that it has been a sense of relief for them because for 2 months there has been a great deal of uncertainty. That means don't know what is happening with me. At least now I know that I've got cancer. Now I'm sure that I can plan my life well. Anger when it is against the disease. Anger can be of different types. When they just said that when the anger is only against the disease, that means that gives the person the strength to fight against the disease, and it is adaptive actually. It helps the person cope. Crying means you're ventilating, you're bringing out all the issues that you have in your mind, you're talking to others, you are ventilating. You're fulfilling an ambition, like you're saying that, okay, now that I have this illness, let me now plan. Let me get my daughter married. Or if it's a young boy, let me finish my studies. I might not live long, but let me fulfill some things, that wishes that I wanted to complete. Realistic hope. So I'm not talking about unrealistic hope, but realistic hope. Let me plan about how I can work with this limited disability. Or let me plan how I can come for chemotherapy from home. So some realistic hope and realistic plan. Let me see how I can plan the next 6 months so that I can have whatever I want, like I can get my daughter married, or I can write a will, or I can, just plan to die at home without pain. So these are all realistic hopes. And of course, denial. Denial is when the person doesn't accept the reality, but cooperates with the treatment, is not hostile to you. So that is a positive coping mechanism. That mechanism, denial, is just a reserve for the person to mask his own inner self from the reality. So he doesn't openly talk about the illness. He doesn't say that I have got cancer. It always appears as if he doesn't, accept that he's got a disease. But he's still cooperating. He's still compliant. He still agrees to whatever decision you take. Then it is an adaptive behavior. Does it make sense? I just need to know because this has no interaction.
Yes, ma'am. After the session, we can have a QA session. Yeah.
So when I'm talking about adaptive behavior, I'm also now going to talk about maladaptive behavior. Maladaptive behavior is one which is maladaptive. That means it is not going to help the person cope. It is not actually going to fix the issue, but it's actually going to aggravate or exaggerate the issue. That means with these behaviors, actually the person is going to have the situation much worse than it is actually, because he's not able to cope. Guilt is one, guilt about how your lifestyle has been, what all bad things you have done. I have smoked a lot. I didn't take care of my family. This kind of enormous guilt. Anger against the helper or the carer. That means it's not against the disease, but I'm angry with my family. I'm angry with the doctor for telling me. That actually kind of makes the relationship worse, and it affects the treatment. So anger against the helper, when I just collapse or go into a state of numbness and shock. Remember the stages I said? Denial. Initially, it's a stage of disbelief and shock. If you're stuck in a state of shock and you're not able to really get out of it, that is actually maladaptive. Constant, persistent anxiety, stress about it. Impossible quest, saying, trying out all sorts of treatment before I'm going to get recovery. I'm spending everything and going to America or going for naturopathy, homeopathy, this and that. Impossible quest. Unrealistic hope, thinking that I'll get better soon and plan something which is not realistic. Despair or depression, where your mood actually goes further and further low. You become constantly and pervasively sad and you're not able to really cope. And pathological denial. Remember, I said denial is adaptive in the previous slide. But what I meant by pathological denial is when the person actually doesn't accept what he has and refuses to cooperate with you, refuses to cooperate with the family, and is not compliant. So that means that he not accepting the disease is actually making it worse for him, not better for him. So we need to know if the response of the patient, the emotional response of the patient is actually adaptable or not. So it is essential to identify whether the emotional response is helping the person, that is part of the solution, or it is making it worse, that is part of the problem. The former is an adaptive response, whereas the latter is a maladaptive response. So I'm giving you some examples of coping skills. Okay. So like one is denying or minimizing, not even talking about it much, not discussing about it, not even upfront about I have cancer, not even always shrugging it off, not talking about it. Seeking information. It is a good coping skill when you seek information in a positive way, not for an unrealistic treatment or an impossible quest, but more to understand what I'm going through, to help me plan my life for the next few months, plan what I should do, how I should do it. Learning to provide one's own medical care. Remember, I talked about self-sufficiency. When I say provide one's own medical care, it's about understanding what one has to then also know what is happening to me, what are the treatment options that I have, do I want to do that, what are the side effects, do I want to spend this much money and take this treatment, how much will I recover, what are the options about after recovery. So I know that and I decide what I want. So that is becoming very self-sufficient and also helping the ethical part of it, that is your autonomy. The good thing is coping skill is to set concrete and limited goals. So rather than say that after this illness is over, after 1 year, I should be okay, isn't it? My doctor, shall I plan my daughter's marriage after that? Rather than that, you are talking about this week and a few days. Like, okay, let the first few chemotherapies get over. Till that, I'm going to focus on no pain, no vomiting, and how I am comfortably going to travel to the hospital and come back. So these are the goals, very concrete, very limited, and I'm going to focus on only small goals for short periods of time to go ahead. And by then, the journey of this cancer will be much more easier and I'll be able to accept it easier. Rather than thinking about all the issues that comes with it and keep worrying, to set small, concrete, limited goals. Recruiting support. Good support from within oneself, your family members, your friends and the community. Very important. Often we need support from others to cope when it's a very difficult situation. It's always good to seek for help, rather than thinking that, oh, if I ask for help, they will think I'm a weak person. Think that recruiting support is a strength of nature and good coping. Considering possible future events. If you know that this is a very serious illness, talking to the doctor about it, talking to how it is going to be, what are the consequences of this illness, what does the doctor know about how is it going to be later, so that you can slowly start planning for it. And to gain a manageable perspective, so that you have, by knowing these things, you actually allowing yourself to have a perspective which you can manage or your family can manage. So you can also think about, see, all of us go through this. This is not for the patient population out there. So let us not mistake thinking that, okay, this is only for some other persons outside, it's not for me. No, all of us go through emotional issues, and all of us are coping, or every day we are coping with several matters. It is only that the intensity varies. So we can also think about what type of coper are we. Are we a confrontative coping? That is, we challenge, we go directly into the issue, challenge and get to the bottom of the issue and start coping. Or are we the ones who would distance? There are people who are very anxious, don't want to be confronting, but also have a safe distance, not directly confront, but distance and address the issue. Am I going to just focus on my control issues? How do I control this? Self-control. Seeking social support. Sometimes I might just let myself take a step back and allow the support that comes from family and the society. Am I going to accept responsibility? Or am I going to just escape from the situation by avoiding? Am I going to focus on solving problems with, I said, concrete, limited goals that you said? Am I going to look into problems, small problems, and solve it through this journey? Or I'm going to reappraise my situation that I have positively. What I mean is, if I have a cancer, for that man, he doesn't have, he's lost his son, he has financial difficulties, he has lung cancer, which is quite serious. So how do you positively reappraise it? So you have a negative news that has come to you, but then I can always say that, okay, I have this illness, but I am with a good doctor now. He has assured me that he will give me good treatment. He is also communicating with me. So I have a clear idea of what is going to happen. My wife is there to support me. So to look into, whenever you remember, when we talk about giving bad news to patients, we always say when you give negative news, you always couple it with some good news. Similarly, when you do it yourself, you appraise your negative situation by looking into the positive. So when you do a reappraisal, look into the positive factors which are attached to it. So this actually helps that. And when we talk about a chronic disease, it's not about only the coping that happens when you lose, when you're told the diagnosis. It's actually a process which is very long term. The adaptation means it's making changes to adjust to life circumstances for a long time, maybe 1 year, 2 years, 3 years, 5 years. So what we talk about in palliative care is very important, and that is quality of life. So that is why we focus on how we can improve the quality of life. So when you're looking into adaptation, and when we are assessing how this person is coping, how is he adapting, we have to look into all these aspects that actually define quality of life in terms of fulfillment, purpose, personal control, relationships, activities, personal and intellectual growth, and material possessions, and many more. So I'm not going to talk details, but many things contribute to what is quality of life. So how do you proceed? We are coming back to the persons, remember. So this person, I've added a few more things. He's 68-year-old with lung cancer. You have told him that he's lung cancer. The rest of the things are the same. But he also knows that there is poor response to treatment, and he has also have some bone secondaries. So that means that there is a serious element to his illness. So this kind of a person. So now you know when this person is there, you have to check into what his emotional responses are. So when he says he's tired, he's overwhelmed, he's not sleeping, he's getting irritable, you're not only thinking about the acute thing of, okay, it should be due to his disease, and it should be due to his pain. He's not sleeping because he's got lung disease and pain. No, remember that when you say psychosocial, remember the psychosocial tasks I said. It's about how you want to be positive, how you want to remove negative thoughts, how you want to cope well with the journey of cancer, how you want to have others see you in a positive image, how you want to function well psychologically. So that is psychosocial, psychological functioning. So I'm going to now, so I talked about emotional responses, I talked about coping, how is coping, and how to understand about coping. Now I am going into certain things which we need to know. How are the ways of looking into it? There's always a confusion when we discuss with teams about, okay, we know that a person responds emotionally, but then what is the framework with which we would approach a person? In a very simple form. I'm not doing this in a technical way, I'm doing this in a simple framework. So there are three ways that you can look into it. One is we can look just as the emotional responses, which is usually what we do. We say that person is angry, this person is crying, this person is not talking. When we go for home visit, he just turns his head and sleeps. So he's withdrawn. So the one is, we always describe people as having emotional reactions, which is very common. One is, how do we fit these emotional responses into concepts that have been developed to look into psychological issues. And third is signs and symptoms of psychiatric disorders. Is that clear? Like, we can look into this into several ways. I'll give you examples. So when we talk about emotions, we talk that a person can be fearful, and we can talk about anxiety as well. In many languages, fear and anxiety is the same. Like in Malayalam, pedi. It's pedi means, and the person says, "Enki pediyana," we don't actually first know whether he's actually scared or whether he's anxious. There is a difference. So we have to actually reflect in our own language, what does the person actually mean when he says he's fearful or he's anxious? Because fear and anxiety are very different emotions. We should not club it together. So the psychological suffering of fear differs from the pervasive worry typical of anxiety. So fearful is really scared. I'm scared of dogs. I'm scared of spiders. That is fear. I'm scared of the dark. Fearful. Anxiety is worrying. I'm worrying what is going to happen to me. I'm worrying about what this medication is going to do. I'm worried what the doctor is going to tell me. So there is a difference. Fear is an abrupt, unpleasant emotional response caused by anticipation or awareness of danger. Whereas anxiety is prompted by generalized, non-specific threats and cues. It is objectless. Usually it is a very general feeling, and the threat is to oneself and one's existence. So we should know, I'm just giving you examples of how we can understand a person's emotions. So if it is fear and anxiety, how it is different. The second is sadness. This is also a common emotion, sadness. Sadness is also very different from grief or depression, which is always confused. So grief is when you're going through a loss, when you go through emotional process. Whereas depression is a clinical state of having low mood and several other factors, which has a profound and pervasive quality. So appropriate when somebody loses something, that is when there is loss, or when you're told that you have an illness, there will be sadness. It's normal. Okay, all of us will feel sad. But we should look whether it is only an appropriate sadness, whether that sadness is there, but the person is able to cope with it. All of us get sad due to various conditions daily or, in our life. But we cope spontaneously, the parallel both, automatically, psychologically, we are also coping. So the sadness disappears. Whereas when it is grief, it is a normal process when there is a loss, but it takes time. And depression is actually a clinical state with clear mood changes, loss of interest, pessimism, which will need help from a trained professional. So these are the two examples that I'm talking about, emotional reactions. This is also important when you look into a person with cancer, for example, because there are stage-specific challenges that a person has to usually go through. Like in initial stage, there is reactions to diagnosis, coping with symptoms and treatment, loss of control, etc. And after the treatment, when there is remission also is not easy, because there might be some physical damage, constantly reminding the painful reminders of the illness. So the person is actually not relaxed during a remission period. There is a sense of uncertainty. What is going to happen? Am I going to get the illness again? And of course, when there is a relapse, there is disappointment. And then the certainty of death comes and the fear of painful death. And along all the state-specific challenges of the illness, you have problems interacting with the health system that all our patients go through. The challenges that the society and the health system brings. So again, I'm coming into a diagram of the grief cycle. This is one concept we can fit in. If the sadness is because of grief, you can actually, you have to identify whether it is part of the normal coping process. So if it is there, the emotion is part of this coping process. This is one concept that you can fit in the emotion into. It is part of the coping process for loss. Remember the 5 stages we discussed about that Kubler-Ross had contributed. Another concept which has been contributed by the National Comprehensive Cancer Network is distress itself. Distress is a broad definition. It is a unidimensional or a unique construct. That means you can actually say whether someone is distressed or not. You won't get more information from that. So when you say a person is distressed, we are not talking about physical distress. Here we are talking about unpleasant emotional experience of a psychological nature. That means when we say psychological, it can be cognitive. That means thinking. Cognition means thinking. A person's thinking. Behavioral, how you behave. And emotionally, how you feel. These are all different processes. How you feel, how you behave, how you think. These are different processes in a person. We should not combine all this. And also it includes social and spiritual issues as well. And this interferes with the ability to cope. So distress is a new concept which has been contributed to understand that. Another concept is suffering. So there are a lot of, now we know that, we are even terming everything as serious health related suffering as the Lancet has come up. So the alleviation of suffering is crucial in all forms of all medicine, especially in the care of the dying. So the experience of the illness and the suffering of a person encompasses everything meaningful to that person. That means including their beliefs, their wishes, dreams, purpose and meaning in life, body image, roles, identity, relationship, and how they make sense of the illness. So it's a very large or a broad, comprehensive process that we term as suffering. So there is also another concept which was contributed by Dr. David Kissane, which is called demoralization. So there are several concepts which have be contributed to understand, to fit in this. One major concept, again, as I said, is quality of life. Remember, I talked about quality of life. It is a multidimensional quantification of the patient's functional status perceived by the patient. So the person decides whether I am depressed or not. And usually there are 7 dimensions: physical concerns, functioning, family, emotional, treatment satisfaction, sexuality, which we don't discuss about in our settings, very important, but sexuality, social functioning. It's one of the most commonly research-based concept in palliative care, especially when you look into psychological issues. So what I'm saying is, either you are looking them as emotions, you're trying to put those emotions into the concepts I said, either as quality of life, either as distress, part of distress, either as part of loss of and the grieving process, or bringing it under demoralization or suffering. So I'm going to actually, I think, going to stop again, coming back with a case. So I think that's correct. I am correctly taking 35 minutes, 3:45 now. It started at 3:05 or something. So what I want to, y'all to, I know that it's a case presentation. I have not gone into anything related to psychiatry today. That will be in the next class. What I want to, before that, I want you all to understand is the psychological framework on which we build up these concepts. That means, how do we identify emotion? How do we explore emotions? How do we put them into concepts and proceed further? So we looked into distress as a definition. There is a tool that I will show you in the next class where we can use that to assess persons. So the questions that someone would ask is it normal for a person to worry after being diagnosed with cancer? It is normal, isn't it? It is normal for any one of us to worry after being diagnosed with cancer. Then what is the difference between normal worry and an anxiety disorder? So that is something which we will take up next class. So I'm going to stop now, and then we'll go into discussion and case presentation.
Thank you so much, ma'am. This is a kind of vast area, but I think you could get some few ideas about how to relate our emotions, at least as a personal life. So, dear participants, this is the best resources we can ever get for this particular session. So kindly clarify your doubts. If you have any questions, please do ask. Yeah, Pranab Kumar sir.
Am I audible?
Yes, yes.
Thank you, Dr. Chitra, for your elaborate discussion. I want to clarify one thing. The relationship or bonding between the patient and spouse means primary caregiver. If it is strong, mental health condition doesn't deteriorate. But if it is weak or bitter, then mental health condition turns into depression and even attempting to commit suicide. So to my mind, we the social support groups can we apply psychosocial therapy to the caregiver, either husband or wife, realizing the psychological stress the caregiver is passing through?
Thank you,
So,
sir. Are you finished? Okay, so you want to continue? Please continue.
Recently, I went to some patient's home as a counselor. So I observed that the patient is slips into depression, and dementia has been developed. So her husband is a doctor, renowned doctor, but aged. He now also he practices. But what I observed, that the patient needs good company from her husband, and because in our communication, the patient smiled, but she sang song. She wanted to sing duet with her husband, and all these things. But this is the relationship depends on the depression depends on the relationship between the patient and the spouse or caregiver.
Thank you very much, sir. I just want to thank you for pointing out that relationships are very important. I did say when you cope, you need to recruit support and especially have good relationship from within the family and outside. But what I want to point out there, what happens is that's a good thing. We should have that. And if it is not there, we should try to facilitate communication and try to help build up that kind of a support that a person would need if it is possible. If it is not there, we cannot create support. But what we can do is have a meeting with the family, the primary carer, find out what the issues are, if there is an issue, or find out how they support each other. And if there's any way we can facilitate that, we should do that. I totally agree with you in that aspect. But I want to clearly point out one thing. That doesn't compensate for the individual. Like you said that, suppose I am going through a lot of distress, for example, okay, because of certain reason. I am feeling very heavy. I'm not able to really focus. I am crying. I'm not able to sleep. Even if I have a supportive husband, even if he allows me to sing or dance, it might not work. So what I'm saying is that doesn't compensate for everything. Of course, it is a great support. It is a resource that we should use to help the person cope. But that, I think from this session, I want you all to understand is that the individual is the most important person. If you are going through something emotional, sorry to say that, but if any one of us is going through an emotion, just look at yourself, reflect on each one of you. If you're going through an seriously distressing emotional state, how much will another person help you? So that is necessary. I did say that we need to recruit support. But first thing is, how am I coping? Where is the strength within me? What are the limitations that I have? Why am I not able to cope? Why is that I am responding like this? Do you understand the difference? So please start looking at the individual first and then the people and the environment around. So what happens is when we see a person, I'm just giving you an example. What happens is when we see a person distressed, we immediately assume an attribute. What we would say is, this is because she's got a husband who's very alcoholic and he doesn't support her. Or we'll say, oh, she's got 3 children, they are unmarried and that is why she's very emotionally upset. Or we'll say there's a great financial difficulty, that is why she's emotionally upset. But there are people with all these things who cope well, isn't it? There are people whom we know who have got alcohol husband for the whole life and they cope well. So what is it in that individual that makes her not cope? So that is very important for us to understand. Otherwise, what will happen is that in our assessments, we will keep on attributing to factors around that individual, but not to that individual. Is that clear? I just wanted to highlight that point. I need some interaction from others to to give me this thing that whether what I'm saying is making sense.
I think the participants wish to add something. Grace, would you like to add something?
Well, I was listening to what ma'am was saying, and I think ma'am is right. It's very important now we look at the patient. I mean, the person of the patient. When we learned in beginning therapy, we learned that is very, very important. Then only we can help the patient to it's his or her own benefit. Quality of
And
life
when I
for
mean
the
the patient also, I think try talking to them, exploring what is going behind their mind, what is worrying them, what are their thoughts, what are the negative thoughts they have, or how are they coping. That is very important. So unless we do that, we'll always fall short. We will take care of physical symptoms, and patients also will not tell you. See, this is not something that everybody would come and tell you. I am not sleeping well. I am not coping well. I am crying the whole day. It's very difficult for people to come and say. They might easily come and say, I have pain. This morphine is not enough for me. They will easily tell you that. But to say that I am constantly feeling anxious, I'm feeling vulnerable, I'm constantly worried about what is going to happen, is something which people might not openly say, and we have to open the doors for them. So if you ask questions, I'm going to talk about it in the next class because I have not come to assessment and anything this time. Here the focus has been only about the framework and the concepts.
Yes, Divya, you raised your hand, so.
Even I agree with what ma'am said, and we have seen several cases where the patient's carers and the whole set of the family and relatives and friends and even neighbors are very cooperative, very supportive, and very lovingly they approach the patient and help the patient throughout. But still the patient never accepts it. The situation never changes and he is miserable throughout. Even his physical pain also doesn't get relieved in spite of quite a heavy dose of morphine also. We have seen patients where there are quarrels and there are conflicts in the society, within the family, but still the patient is okay in spite of the conflict.
Thank you for pointing that out. I want each one of you, see, and that is exactly what we learn when we say empathy. It is about putting yourself, we always very cliched way of we say putting yourself in their shoes, say. But do that actually, when you see a situation, when this person is coming to you, 68-year-old man, all these things, think about how you would feel if you had been told that it is cancer. How would I react now? What would be my emotional reaction? If your husband comes and reassures you, will it make it okay for you? What is it that makes it difficult for you to cope? It will be very, very different from you and another person. So think about that. Always, this is what is called empathy. When you actually think yourself in that situation and how you would respond. When you reflect on, if you even think of what has happened in the past, when you have gone to cancer, when you have gone to a doctor for some illness or something, how have you talked to the doctor? How have you communicated? What has been your response, emotional responses? Were you worried? What did you ask the doctor? If you start actually focusing on how you would actually behave, it actually reflects a lot on how we actually understand the patients also.
Yes, ma'am. I think Shalini also would like to add something. Shalini?
Yeah, thanks. Hello, ma'am. This is Shalini.
Hi, Shalini.
Glad to be in your session. Ma'am, I just wanted to add a perspective here. A lot of times when we are trying to even fix the family situation or the response, the family caregivers, there are a lot of baggages that these relationships hold. And sometimes it is like a futile efforts that we are giving into family members to counsel them to help the patient. And there's so much of baggage, it's very difficult to really counsel them or convince them.
So that's because, I'm sorry, you had something else?
No, I think that's why I feel that what you are saying to focus on individual first is most important, because it's very difficult.
And also, Shalini, I think it's also important when we are talking to others, caregivers or something. Our attitude is always, we think that we should offer solutions. So like you said, we want to fix problems, fix the cake. We cannot do that. We can never fix another person. Can only fix ourselves.
Yes.
So we have to realize that. So it is about facilitating the process.
Correct.
It is the patient or the caregivers, we can only facilitate the process. We can never give a ready-made solution for anyone. So what we're trying to tell them is, it's all about negotiating, telling them, is this possible, and how do you feel? So I remember Dr. Rajagopal saying that you keep just asking what and why to the patient or the caregiver. Why is this happening? What do you think? How can we? You just allow them to find solutions. You just help. See, you're just this aid, like this PowerPoint, which I use to bring in the concepts. Similarly, we are just an aid. So we keep asking them why, what, how, and you see it will unfold. Rather than, our tendency is to find this problem and then fix that problem.
Correct. Correct.
Ma'am,
I do have a question also. Sorry.
No, tell me.
Okay. How do you handle fear of death in a patient? Like the patient knows that I'm going, and somewhere inside him there is something that is telling him that I'm going.
So how do you know it is fear? From the beginning, let us start. How do you know it is
not
fear?
in a state. It's like,
why did you say
suppose
fear?
Fear because when the person is talking about, like, the doctor did this to me, it's like, yes, he has taken away everything. Now the person who has never cried, he's crying every time. Who has never been emotional,
So
he's emotional
why do you
now.
assume that it is fear? Why can't it be relief?
Because because of his facial expressions.
Ask him again. Ask him, why are you crying?
It's an emotional reaction, like when he's, suppose, an old person talking to a grandchild, and he's like, oh, I don't know when I'll be able to talk to you again. And then very anxiously, the eyes are wide.
But that is a very normal thing, isn't it, Charlie? That I say that.
How to handle as a...
No, if it is an appropriate emotional conversation, you allow it to happen.
Okay. We allow it to happen. We don't have to do anything.
If there is fear, you allow that fear. Because everybody will be fearful. I will be fearful. You will be fearful. So we cannot tell him, don't be fearful.
Yeah, of course not that, but how to, like...
What we can say is, if you think he's fearful, you can even ask them, I can see you're crying. Is it because you're fearful of something that is going to happen? Will you be able to talk to me about it?
Okay.
So if he's going to talk to you, if he's going to say, I'm fearful, you should ask, why do you think that is fear? I mean, why are you fearing? Is there something specific which is making you feel anxious or fearful of death? So it will be something like, something like they would say probably, I'm afraid of the pain, or I'm afraid that I will not be at home. I'll be in the hospital. So there are many things that probably you can manage. You can say that I will actually make sure that you don't have pain. Is that okay? We'll assure you that. Many things you can assure. We'll make sure, we'll talk to your family, and we'll make sure that you are not shifted to the hospital at that point.
Ma'am, just one thing. Shall we say that, no, you'll get well?
No. If he's not going if he's not going to say, get well, just sit with him. Your presence is enough.
Okay.
Again, Charlie, we should think of ourselves. I'll give you an example. Suppose something terrible is happening with us. Do you want another person to offer you solutions if you're fearful of something or anxious about something? Often you just want to sit with someone and just ventilate or help someone, tell someone, get it validated. You're not asking people to solve that issue.
Right. Cool. Thank you, ma'am. Thank you so much.
I don't know if that made sense, but...
No, definitely it made sense. Thank you so much.
I think it's now time for the case.
Yes. So thank you so much, ma'am. I think we have the case presentation from Mansi.
Ma'am, can you stop your screen share so that we can...
Yeah, sure. I'll just take it off.
Yeah.
Hello.
Yeah, so we have Mansi Mondal from Eastern India Palliative Care. She's a KISO coordinator, so she'll be handling a case presentation from 4 to 4:15. After that, we can have a discussion related to the case. So over to you, Mansi.
Good afternoon, everybody. Hello.
Hello.
Can I audible?
Yes, yes.
Hello.
Yes, you are audible.
Yes. Good afternoon, everybody. Today I will present my testimony on mental health. Patient is 45 years, male. Diagnosis is CS metastatic stage 4. Date of
Mansi,
diagnosis 7 October.
Mansi, one
Hello.
second. Yeah, could you please take the mouthpiece closer to your mouth so that we can hear you properly?
Hello. Can I audible?
Yes, yes, like the way.
Patient is 45-year male. Diagnosis of CS metastatic stage 4. Date of diagnosis 7th October 2017. He is on medication. Ciprofloxacin 500 mg, paracetamol 650 mg, pantoprazole 40 mg, Ondem, mifepristone ointment. Liquid diet is given by FG tube, nothing oral. Next, this is a genogram. Father is the patient is died. The patient lives with his mother and younger brother. Both brothers are bachelors. His grandparents died. The patient had uncle and aunt who passed away. He has two cousins, but he has no bonding with them. There is a strong bonding between his mother and younger brother. Younger brother is a primary caregiver. Next. Patient diagnosed with gastric ulcer proliferative mass malignant on 7th October 2017. He was under homeopathic treatment for 1.5 years. After his health was worsening, he got admitted to a local nursing home. Biopsy was done and diagnosis purely differentiated carcinoma. He was admitted to Kolkata Medical College on 10th May 2019 for exploratory leptotomy GA incision midline. Now it has been diagnosed with CA stomach metastasis. Liquid diet is given by FG tube, nothing oral. Patient came with so bad condition, doctor has unable to give any kind of curative treatment such as chemotherapy and radiotherapy. Due to patient poor condition, doctor has advised him to undergo palliative care treatment under the guidance of EIPC Eastern India Palliative Care. The decision was taken in Tumor Board of Radiotherapy, Kolkata Medical College. Next, family history. The patient lives with his mother and younger brother. Both the brothers are bachelors. His younger brother is the sole caregiver. Father of the patient is died of CA gastric ulcer. Next, social challenges. He does not have any meaningful social support from their friends and relatives. Social support is available. He is well social support by his mother and younger brother. At present, EIPC provides his emotional, mental, and medical support through home visit emergency. As he is passing through depression, anxiety, deteriorating mental health condition, we are trying to boost mental power to come out of depression. Counseling plays a vital role. Next. Financial condition. The patient is by profession auto driver. Due to poor prognosis, his income stopped and financial condition is very bad. His mother is a widow pensioner who support financially. His younger brother having a small business give little support. Loans and debit if any, no. Scheme and subsidies available. Chief Minister Relief Fund, Prime Minister National Relief Fund, Swasthya Sati Fund, Rashtriya Swasthya Bima Yojana are available in West Bengal. But in government hospital, cancer treatment are free. So Chief Minister Relief Fund, Prime Minister National Relief Fund are not applicable in government hospital. Swasthya Sati Fund and Rashtriya Swasthya Bima Yojana are applicable when patients are admitted in hospital. For this patient, all above scheme not applied as they do not fall under BPL section. Scheme and subsidiary access not availed. Next, education status of children not applicable. Job status of family member, mother is a widow pensioner and father runs a small business. Next, patient inside of diagnosis. The patient is well aware of his diagnosis and disease. Patient inside in prognosis. The patient is well aware of prognosis. Next, caregiver inside of diagnosis. Well aware of diagnosis. Caregiver inside on prognosis. Well aware of prognosis. Next, mental status examination. Component of MSc, patient and caregiver. Appearance, build, postures, dress, grooming, level of alertness, emotional, facial expression, attitude towards the examiner. Patient, tidy, malnourished due to difficulty in swallowing food, tired, weak, cooperative towards the examiner, facial expression, speak to poor mental health. Caregiver, tidy, well-built, seems stressed, anxious, cooperative. Behavior, eye contact, movement. Patient, maintaining eye contact, normal, but look depressed. Caregiver, maintaining eye contact, normal, sometimes agitated due to harassment, experience in government hospital. Speech, rate, volume, content. Patient, decreased and soft. Caregiver, talkative with excitement while explaining the status of patient. Mood and affect. Patient, anxious, depressed, feeling hopeless about the outcome of treatment, suffers from delirium, irritated due to not fulfillment of hunger. Caregiver, anxious, irritated about the treatment, saddened. Thought process, organized. Caregiver, organized. Thought content, patient and caregiver both normal. Cognition, conscious orientation. Caregiver, conscious orientation. Insight and judgment, both are normal. Next. In the beginning, patient was under homeopathy treatment and confidence that he would be cured. When the disease progressed, his level of confidence deteriorated. First, he did not inform family members of the disease. When he was admitted to hospital, his family members came to know. Now he slipped into depression. His psychological condition is worsened. The patient does not want to be a burden. Next, goals of psychological care. To build empathetic and harmonious relationship so as to develop trust on the caregiver and the social support groups like EIPC. Counseling is a need to boost mental power and emotional support with the patient and the caregiver. To motivate the patient to come out of depression, caregiver must be advised to take own care. Frequent counseling, home care visit, good communication will help the patient to be steady in mental health. Next, summary. 45-year-old male patient with CA stomach metastasis is suffering from depression, severe mental health condition. The treatment is still going on. The patient is now under palliative care. Next, discussion point. How palliative care might support someone approaching the end of life with severe mental health condition. Next, what does the psychological illness resulted from depression of the patient with advanced cancer?
Thank you, Mansi. So we have two discussion points. One is related to end of life care, how we can deal a person in that particular stage considering the mental health condition. And the other one is depression state of a patient with advanced cancer.
Yes.
Chitra ma'am, are you there?
I'm there.
Yeah. So we just need your guidance to start up with the discussion points.
So actually, I thought the management part, we should just leave it to the next session because we are not looking at, I think even when we divided the topics for the schedule,
Yeah.
that we will not talk about disorders or management today. So I don't think I'm going to talk about how to manage a person with mental health condition.
Okay.
What are the physical illness resulted from depression? But I didn't understand the question. Mansi, can you just say what did you mean by that? Physical illness resulted?
Changes in appetite and weight, sleeplessness, poor concentration.
So the thing is, again, that comes under management. First thing is, I appreciate you, Manasi, to bring this,
Thank you.
and I think probably I'm seeing the first time mental status examination tables. And do you have a psychiatrist in your team? Mansi,
Hello, ma'am.
is there a psychiatrist in your team?
No, ma'am.
Okay, so who did the mental status examination?
Patient come my OPD. So we are
You did the mental
talking
status
with.
examination? The one in the table? Remember the table, MSc?
Hello, ma'am.
Aren't you here?
Yes.
So what
Yes.
I meant is, who did the mental status examination? Did you do it? I'm saying that detailed mental status examination usually I don't see in case sheets. So I was just thinking who did it in your setting. Anyway, it's
Help by my team. Help.
good that you're doing it. That's why I wanted to ask that. So there are many things discuss. I think the discussion points, both this would probably come after the next session, because I've not talked about depression or any psychiatric illness today. So management, I haven't shown you the slides yet. So this will definitely come in the next session about managing how with a person with depression, with anxiety, all those things. I just want to point out a few matters. Can you bring that table slide? So here, it's very good that you are actually doing this because I think it actually, if you're doing this, that means that you are exploring a lot of things with the patient. But there are some things I want to just clarify. That is, when you talk about mood and affect, and you say anxious, depressed, feeling hopeless, and then you're also writing suffers from delirium, irritated due to non-fulfillment of hunger. So I didn't understand how delirium came into play, because delirium is another psychiatric disorder. So if you diagnose delirium, you will not diagnose depression. So then it's totally due to delirium. Do you understand? So when you diagnose something, so delirium is a diagnostic disorder, depression is a diagnostic disorder. So when you're diagnosing delirium, then you can't diagnose depression. Because if there is delirium, then the person will not be oriented, his thought content will not be normal. Do you understand what I'm trying to say?
Okay,
ma'am. Mood and affect. So that is why I'm trying to say that we have to be very clear about the emotional expressions that you define. So to say that he's anxious, he's depressed, he's delirious, everything in a same person will actually confuse you how you should go ahead. Am I helping you?
Yes.
Okay.
Yes, ma'am.
I know that it's a difficult, it's a topic that usually we don't discuss, or people who are not trained in mental health assessment find it challenging to do this. So I appreciate that you have done this well.
Thank you.
So another thing is, I want all of you to reflect this patient in the framework that I said. Like, how can we actually assess the person in terms of his emotional responses? So he's very sad, or he's fearful, or he's anxious. You remember I said either we can describe as, whether he's fearful or anxious, whether he's distressed. What is his quality of life, and what are the components that you look into the quality of life? That will give you a much more of an understanding of what is actually happening to him. So in this, I get an idea that he's anxious and depressed because he said that he doesn't want to be a burden. But when we want to understand more about the person, we have to explore further to what is happening with him. So sit with him, talk to him, ask him again, why doesn't want to be a burden? So many things. I know that you have given a lot of social and social issues in terms of money, food, which I agree that are big factors in getting the issue. But I want you to focus, or each one of you to focus on the individual. So the thing to understand, how is this person? The person is feeling very sad. He doesn't have much support from others, but except his mother and brother. There is a lot of financial difficulty, isn't it? How is he coping?
Yes,
So I
yes.
need to know how is he coping. So instead of directly diagnosing him with depression, let us go step by step. How is he coping? What is his loss because of this illness? Individually, I mean, I have lost my identity. I have lost my role in life. I have lost relationships. I have lost a position. I have lost a job. Is that making sense to go about it that way? How is it affecting him? So we know that he is depressed. We know that he is anxious. But what is beneath that? What is his thoughts? What are his feelings? Why is he not able to cope? So was he a person who coped well in the past? How was his past like? Was it a very smooth life, or did he have several come and go in other forms in his life? Then who supported him? How did he cope then? You understand
okay,
that?
understand.
So try to build that as a person rather than just going into the diagnosis of depression. So as a person, what do I know about him? How can I know more about him? How has he been coping? What are his emotional responses? Why is he so sad? What are his concerns now? I think that stepwise assessment of a person and having a framework to understand more about him, and then going into, okay, he's not coping well, his sadness is very deep, he's not sleeping for a long time, then you think, oh, is this a pathological state? So is this a disorder? Is this a mental health disorder? Am I making sense to everybody?
Yes, ma'am.
Because I just don't want us to just talk about disorders. I want us to really understand the experience of a person with this illness, understand how we can assess them sequentially, stepwise. Meanwhile, when we just assess, we are also actually building up the relationship with him, the rapport with him, understanding deeply about his issues, and then go into a diagnosis.
I think it's clear to everyone that it's simply we can't use depressed, anxious, fear. Yeah, so we need to relate our emotions with accurate theoretical base.
I will give you an example. Suppose I am very sad, or you are very sad about something. If somebody said you are depressed, you are delirious, how will you feel?
Yeah, it's totally different.
Yeah. So that is it. Are we really diagnosing on the basis of a psychiatric framework for the disorders? Or are we just attributing because he's sad, then that it must be depression?
Yeah, it seems while we are hearing the word depression, it usually creates a kind of, oh, that person has some kind of mental issues.
That is it. So let us not actually use these terms to label them immediately. That is what I'm trying to say. So as a team, especially as a palliative care team, what we should do is do the work before that. Spend time with them, talk to them, understand them, ask questions, explore, find out how he is as a person, how did he cope in his life, is he coping well, what is the situation like now, what is he afraid of, like Charlie said, what ask him, why I can see that you are very sad, empathetic statement. Can you tell me more about it? Find out further and further about what is happening. Talk to the mother. How has he been? Is he behaving differently? Rather than just making a mental status examination, have a framework to understand the relationship, understand their emotional responses. I'm not saying he will not have depression. Okay, don't get that feeling. He could have psychiatric problem, but let us go step by step. Does that make sense?
Yes, ma'am. I have one clarification there. If we want to do the mental status examination of a particular person, how many sittings or how many sessions at least we should spend with that person? I know it varies from person to person, but at least for a minimum.
See, like actually you will take around 1.5 to 2 hours to do the whole process. So it depends on whether you can sit one whole morning with a person and do it, or whether you want to do it in pieces. And it also depends on what level you are in. Like for me, I will do it very quickly because I'm doing it every day in my life with multiple people. So it depends on also how much you're trained, how much of skills you have.
So I think this is one sort of guidance and advice from Dr. Chitra to social workers family. So while doing the MSc, we need to make ourselves aware about what is exactly the patient is going on and what kind of emotions we can relate. So that is what exactly ma'am has described all through her sessions. So ma'am, is there anyone wish to say anything or? If no, we can wind up for today. Chitra ma'am, thank you so much for elaborating and thank you so much for finding your time to.
That's okay. I just hope that because I really understand that this is not a very objective kind of subject where you can measure something. I can't give you a tool to say that measure the mood or something like that. It's something which comes with experience, with your skills getting fine tuned. You know, it's like singing, learning to sing. You know, you learn under supervision, training, what is wrong, what is right, kind of thing. So let us learn the basic skills, like your communication skills. You have to, keep working on it so that rather than us going directly to find out whether they're actually depressed or anxious and whether they are, I think as a team, it's enough actually at the first level to even find out that the person has an emotional distress. And if you feel that there is emotional distress, you can refer the patient to a trained person. Do you understand? So at least we should start a pathway. We have to create a protocol. So at least first everybody should start exploring these things rather than just thinking whether this is depression or anxiety disorder. I hope you understand that. That is what we want to actually build up. So that we can say that when we are actually able to identify people with issues rather than saying that there is so much of depression in our patients.
Yeah. That's it. So I think now onwards we need to rework our mental status examination. We have already done.
Do it. I'm not saying don't do it, but
Yeah.
also do the work that you have to do before that, like
Understanding the person more. So Pranav Kumar sir, quickly you can express. Sir, could you please unmute yourself? Yes.
Ma'am, is it necessary for empowering people with mental health illness with health service?
I didn't understand, sir. What did you mean empowering?
Empowerment, actually, in a mental health context, empowerment is a factor, is a level of choice, influence, and this empowering people. If we empower people with mental illness, so they will be alerted, they will be motivated, they will be mobilized.
I didn't really understand. When you meant empowerment, did you mean empowerment of the team or empowerment of the patients or the
patient?
See, empowerment is natural because once that is what we do with the sessions. When people are aware, that's what Deepika Padukone does. She tries to improve the awareness and empower people to identify if I have anxiety or anxious depression. So when people know that there is something really serious, I can myself come and tell you that, doctor, I'm feeling so distressed that I need help. So seeking help is also very good. So for that, you have to empower them. Our patients usually do not come out with it, so empowering them is a good thing. But we have to empower them in a very appropriate manner.
So I think it's clear. Thank you so much, ma'am. So thank you, participants, for your participation on time and considering this session as an interactive one. So we will be seeing you next Friday with another topic on addiction.
Thank you. So I think I'll do the next session continuing.
Yes, continuous session.
Today will come for the next day because it will be a continuous session on how
Yes. Mental health session we will be continuing on next Friday, 4th Friday of October. 4th of October, not 4th Friday, 4th of October. So thank you so much.
Thank you. I'm just signing off. Bye.
Thank you, ma'am. So I have shared the feedback. Please do the feedback and then leave the meeting.